I'm Lauge Sokol Hessner, and I'm excited to join you today to talk about acute emotional distress in healthcare. I'm a clinical associate professor of medicine at the University of Washington and Harborview Medical Centers in Seattle, and also had the pleasure of working at Beth Israel Deaconess Medical Center in Boston, the Harvard Teaching Hospital, for quite a few years before recently relocating here to Seattle. I don't have any relevant financial disclosures and would just say that any opinions shared today are my own. Do not represent the university that I work at. My objectives today are to just explore this issue of acute emotional distress in healthcare with all of you, really taking a comprehensive look at that. We're going to talk about the science of empathy and then outline several approaches for responding to emotional distress. So as we think about acute emotional distress in healthcare, I want us to think a little bit about who is suffering, what is the nature of their suffering, when that's happening, and what are the mechanisms of action? How exactly are they coming to have that acute emotional distress in healthcare? And I think it's really by looking at these underlying factors that we'll be able to think about what can we do about it? How can actually we prevent it and hopefully mitigate it and make it better? So as we take that comprehensive approach, I want to think about a Venn diagram about suffering in healthcare among patients, families, and professionals. And as we think about the patient perspective, there are two big buckets that I think about. One is the physical suffering that happens. We're all unfortunately familiar with the pain, the disability, death even that can happen in the context of healthcare. But there's also a lot of non-physical suffering. And today, with acute emotional distress, this is really what we're going to be focusing on. And non-physical suffering can really take a bunch of different manifestations. So people's emotions, their psyche, their self-image, their relationships with others. So patients' relationships with their loved ones, with their families, with their healthcare professionals or healthcare team may be altered as a result of suffering in healthcare. They may actually have different care-related behaviors going forward. As we talk about today, we'll see ways in which acute emotional distress can actually affect patients' willingness to share or divulge sensitive information or follow medical recommendations or return for care. This suffering may also extend to their ability to be employed and to their finances. So there's a lot there to think about. And as we add in the family perspective in this Venn diagram, I think we can appreciate that families and family members may have similar non-physical suffering to patients. They don't have the physical piece, of course, but they do share in all of these other negative effects. When I talk about families today, I'm really using a broad definition of family. Really anyone the patient wants involved in their care, regardless of whether they are biologically, legally, or otherwise related. And those people, those loved ones for patients, are at similar risk to have these non-physical effects. When we add in the professional piece, I would argue to you that professionals suffer both the non-physical harms and suffering just as patients and families do, but also have the risk of physical injury, unfortunately, through workplace violence. I think we're all familiar with how healthcare has some of the highest rates of workplace violence and injury compared to other industries. And so appreciating the breadth of suffering that we're talking about today and then honing in on this acute emotional distress piece, I think is really important, recognizing it's occurring in this larger context of suffering. So as we think about the causes for all of this suffering, I think that will help us focus today. We can all appreciate how disease itself can cause a lot of suffering. Treatments, even when appropriate and perfectly administered, often come with side effects that can be significant. We also know that mistakes or errors in healthcare can lead to these negative effects. Bad interactions, we're going to talk about more, but that's one of the ones I think we need to become particularly sensitive to because it's an area that we can actually have some influence as individuals. And of course, life outside healthcare, we know, contributes a lot to suffering, and that's obviously out of scope today, but appreciating the impact it's having is relevant to what we're talking about. So I want to focus a little bit on this bad interactions piece and what exactly do we mean by that? And to do that, I'd like to think of a conceptual map, a schematic from the perspective of a patient when something goes wrong in healthcare. So we all know that the mechanism of injury for a lot of physical harm can be medical error, right? So diagnostic error, treatment errors, we know can lead to injuries, loss of function, or death. That's very well established, of course. We also, I think, know, and it's well established, that these medical errors can have emotional or psychological impacts. They may decrease patients' trust in healthcare professionals and healthcare systems. The result of that might be fractured therapeutic relationships. They might be less willing to return or come back to the healthcare system, less willing to recommend it to their loved ones, and of course can be financial impacts on everyone involved. So all of this, I think, is pretty well appreciated. The piece I want to add in today is the piece about bad interactions and the ways in which that can contribute to acute emotional distress, or to non-physical harm, as we might call it. Disrespect, and what do I mean by that? It really can take a wide range of professional and organizational behaviors that can fall into this bucket, and it's really defined from the perspective of the person experiencing the harm, the person experiencing the disrespect, so in this case, the patient. I think it's both a powerful and valuable concept, as well as a challenging and complex one. It's valuable in that I think this concept of disrespect resonates with many stakeholders, patients, families, and professionals. And it's powerful for that reason, but it's challenging and complex because the entity that's often being perceived as being disrespectful, so the provider, the healthcare organization, they rarely intend to be disrespectful. That's not why they came to work that day. But that is the experience that the person that they're interacting with sometimes has, and we have to respect that. So it's a powerful term, but we need to use it with care. So I want to give an example of how this might actually play out, and how disrespect, how these bad interactions can actually lead to non-physical harm, and how strong that effect can be. So let's think about the situation of an adverse event having happened, maybe a medical error occurred, and then how the professional and the organization are responding afterwards. So after an adverse event, if a patient or family experience that their concerns are being disrespected or dismissed or disregarded, if they feel that the providers and the organization are being inattentive, neglecting them, or abandoning them, if they feel that the organization has information, for instance, why the adverse event happened and what's being done to prevent it from happening to someone else, but they're not sharing that, instead they're controlling or withholding that information, all of those behaviors can lead to non-physical harm. They can have significant emotional, psychological effects on trust, etc. And so I want to show you some data around this, because I actually think this is a really powerful example of the effect that bad interactions can have on that emotional distress. So let's think about bad interactions in healthcare and how they lead to emotional distress after safety events. We know what disrespectful communication in that setting would be. We just talked about that. But what would the opposite be? Well, the opposite is often referred to as open communication. Those of you that are familiar with communication resolution or CRP programs would recognize this is the approach being advocated for with those programs. And what it would mean is that instead of the disrespectful communication, which would be dismissing or disregarding concerns, the respectful or open communication would be acknowledging and addressing them. Instead of being inattentive, neglecting, and abandoning, it would be being attentive and accompanying them throughout that process after the adverse event. Instead of controlling or withholding information, it would be being forthcoming and transparent. So now if we look at some data, I'm going to show you some data from Massachusetts. The Betsy Lehman Center for Patient Safety is a quasi-non-governmental agency that is charged with improving patient safety in the Commonwealth of Massachusetts. And they surveyed Massachusetts residents, and they asked them, had you had a recent experience with medical error? And 20%, about 1 in 5, said that they had a recent experience. And then they said, okay, well, how did the provider and the organization respond after that adverse event? And what was the nature of their communication? And you can see 2 different lines on the graph here. The orange line is without open communication, so in other words, with disrespectful communication, a bad set of interactions. And then the bottom line there is with open communication or respectful communication. You can see big differences in the proportion of people that felt abandoned or betrayed, sad, depressed, angry, or that avoided the doctor and avoided the facility. So this, I think, is a good example of the strength of the effect of bad interactions can have on acute emotional distress, at least in the context of an adverse event having just occurred. So something for us to think about as we come back to our Venn diagram and understanding the causes here, now that we have a bigger appreciation for what we're talking about who's suffering, how, why, what's going on there, and what's the nature of their suffering, we can begin to ask, well, what can we do about actually addressing those causes of suffering, hopefully preventing it from happening in the first place, at least in some situations. And when it has occurred, when there is suffering, and there is acute emotional distress, how do we mitigate that? There is so much that we could talk about here. We only have a limited time today together, so I want to focus on just a few key areas. One is the concept of traumatic healthcare experiences, which is shared by both patients and families. And the other two are workplace violence experienced by professionals and how we can work on that and mitigate that to some degree, hopefully, with de-escalation, and the contributions that and other stressors have to professionals and how we can better support them through that. So we want to ask ourselves, what can we do about these? And I think one of the common things that underlies or is a prerequisite to being able to address these is really this concept of empathy. And empathy is a prerequisite to being able to do better here. Empathy is the action of or capacity for understanding, being aware of, being sensitive to, or vicariously experiencing the feelings, thoughts, and experience of another. And what we want to talk about today is really how can we enhance that empathy? How can we get better at being empathic and rebuild empathy when it's been lost? Because it's not something that we should be taking for granted. There is a lot out there about empathy. There's a lot of great research and work that's being done. And I just wanted to share a little bit of that with you because I know since when I went through medical school, this has really evolved a lot. And there's a lot supporting the importance of this as a core component of responding to acute emotional distress. Empathy really is an emotional bridge that promotes that connection and a sharing of sensitive information and healthy behaviors. And when patients don't have it, they're dissatisfied, but also less likely to adhere to follow-up recommendations or medication recommendations. They have lower trust and worse health outcomes. When they do receive empathy, when they experience it, they are having better immune function, shorter post-surgery hospital stays, fewer asthma attacks, stronger placebo responses, and even shorter durations of cold. So really an amazing connection between the way in which we interact and people's health, their physical health included. The neurobiology here is really interesting. The studies suggest that when being empathic, physicians, patients, and clinicians can have physiologic responses. And when those are concordant, when they have the similar response, patients actually perceive more empathy and rate the interaction as having more empathy. Neuroimaging studies show that when we are being empathic, when we are vicariously experiencing someone else's suffering, the same proportions of our brain light up that would light up as if we were the ones actually suffering. When we say we feel your pain, we actually can really mean that sometimes. So there's real science behind this. I think one of the challenges is we know that medical school and other training experiences actually decrease empathy. So to be empathic, we actually have to be aware of what it takes and we have to train towards it and value it. So I wanted to share an acronym that I think about when we're trying to think about how to be empathic and what the different components are to may be helpful. And this is a foundation for some of the future things we're going to talk about. Empathy often begins with eye contact and also muscles of facial expression, both our own and being able to perceive others. Perceiving really and observing are a key part of this, both posture and position, patient's affect, their tone of voice, any tactical cues. So when we shook their hand, were they cold and clammy and seeming nervous and tremulous, or was it warm and dry and confident and strong? What are the cues that we can take from someone to get a better sense of what they're feeling and what might be going on for them? As we listen and observe, I think we really need to hear the whole person, not just what they're saying is the matter to them, but what they're telegraphing to us is important. We have to look beyond that initial complaint or concern. The last part of this acronym that I really like and I think is really important, and we'll talk about this during the de-escalation part as well, but it's really this concept of self-regulation. For us to be empathic, we actually have to be attuned to our own emotional state and understand what's going on, and so that we can modulate that as we are responding to someone who's suffering. Sometimes people who are suffering can have a really, really challenging set of behaviors. They may occasionally be manipulative or entitled, even threatening in the setting of workplace violence. So we want to be really able to regulate ourselves so that we can maintain our empathy throughout those challenging situations. We'll talk about that a little bit more, but this foundation of empathy is really underlying the three different responses we're going to talk about today. And again, there's more we could talk about, but we're going to focus on these three for today. Trauma-informed care, acute de-escalation, and peer support are the three. So let's dive into trauma-informed care. Trauma-informed care is really based on the premise that people in life, us, patients, their family members, experience events and situations that are physically or emotionally harmful or threatening, and that at least some of those experiences can be perceived as traumatic. In response to that trauma, it's a human thing to adopt behaviors that help us adapt and hopefully help us protect ourselves from future trauma. Being physically and psychologically safe are key parts of being human and feeling at peace and feeling comfortable. And our responses, while best intentioned and often unconscious, are unfortunately sometimes maladaptive. And when they are maladaptive, they can have adverse effects on our function and our ability to interact constructively with others and on our well-being. And really, trauma-informed care is based on the premise that this is happening to all of us, some more than others, and that we should appreciate and understand that when we approach interacting with people in the healthcare setting. This brings us to the concept of universal trauma precautions, which is really assuming that everyone has experienced trauma and then interacting with them accordingly. And there's some core components to that I want to briefly touch on as we think about doing this work. We can't control others' history, attitude, their support structures, or coping mechanisms, but we can control how we interact with them and how we prepare for that. And I think step one there is really having familiarity with this premise and with the principles and the practice of trauma-informed care. Two is really our attitude. And this is a key piece. I really want to highlight this because I also think it's one of the hardest and can take a while to adjust and improve. But really our attitude refers to how we respect those who have suffered and may be suffering. Especially among those of us who've been fortunate in life to have avoided significant major traumas, it may be hard for us to sometimes appreciate what our patients are going through, especially if they've experienced a lot of trauma in their life, or if they're not necessarily forthcoming about their trauma, because to do so would be making themselves vulnerable and it would be harder to share. Regardless, if we lack that respect for their suffering, we may have a negative attitude towards them that can actually manifest as a negative demeanor or disrespect. And I would argue that a negative attitude and negative demeanor are actually at the root of many of those disrespectful types of behaviors or bad interactions that can lead to more harm. What is our demeanor? Well, it's really our outward expression of our attitude. It's how we comport ourselves based on how we feel or think about someone or something. And developing a neutral and authentic demeanor towards people, I think, is really a critical underpinning of trust and is a core part of this trauma-informed care set of practices. Empathy, of course, underlies all of this, as we've discussed, and our ability to forge a therapeutic relationship, especially with patients that have suffered trauma, really depends on being able to have the right approach towards them. So I want to talk about how we can take these general principles and actually apply them a little bit more in the context of acute de-escalation, because it's a great example of where these really come to bear and how exactly we can put these into practice. We've all unfortunately seen escalation and workplace violence in the healthcare setting. And there are a number of different phases to the cycle of escalation. Sometimes this is called the assault cycle. I think of it as the stages of escalation, but I think having an appreciation for those stages, what's happening, and where we can intervene is really important. The first stage is stage one, and that's the normal stage. That's where stress and anxiety are at normal levels. Patients and family members may be calm, they may be cooperative, at ease. This is the state we would like everyone to be in. Unfortunately, healthcare has lots of stress with it and as part of it, so it's hard to keep everyone in that place, but that's an important stage to try and aim for. Stage two really is when some sort of precipitant has happened, and it leads to rising anxiety and stress and a notable change in behavior. We'll talk a little bit about what are some of the behaviors we might want to keep an eye out for, but really any change here is something to keep an eye out for that might reflect stress or anxiety. That's followed by stage three, where if that anxiety remains unresolved, emotions and stress can really escalate start to get out of control, and people can begin to feel powerless and hopeless. This loss of power and hope, or loss of control, loss of a sense of safety, is really underlies a lot of this escalation here, and is something we need to attend to as we begin to think about de-escalation. The danger here is that these feelings, these strong emotions, can convert to anger, and if they do, you end up in stage 4, which is the crisis stage. And this is the stage we're really trying to avoid. It's where we've lost the ability to really cope with that stress and anger that's rising, and it leads to an outburst. Those outbursts can be violent. Sometimes it might be verbal, sometimes it can be physical, but regardless, this is the stage we're trying to avoid. It's followed by the resolution stage or phase, where after that emotional release, once the severity of the situation resolves, that person calms. They may feel tired or exhausted because of all of the stress they've just been through. They may feel really sad and guilty because this didn't feel good to them either. This, from their perspective, this was a horrible experience. They wouldn't want to relive this, or wouldn't want anyone else to go through this either. So I think appreciating those stages is good. Where we want to intervene, one, we want to have our universal trauma-informed care here, in stage 1, to prevent that escalation in the first place, if possible. But when it does occur, because it will at some point, and we can't prevent everything, we want to try and de-escalate in stages 2 and 3. Really, when we get to stage 4, we're just managing that outburst, that violent behavior. We want to try and catch it before it gets to that. We can do our best effort in these stages, and we know that we won't be able to prevent every episode of workplace violence or every outburst that happens. But it doesn't mean we shouldn't try, and we got to do our best, our due diligence in these stages to try and help. So let's think a little bit together about that. How can we de-escalate? Well, first we have to recognize that an escalation is happening. And as we talked about, there are some specific behaviors we might want to keep an eye out for. The acronym STAMP is often sometimes used: staring, tone, anxiety, muttering, mocking, and pacing. I think that can be helpful. Those are pretty obvious signs, I think. There can be more subtle ones, however, and really any significant change in behavior that reflects stress or anxiety is something we need to key into and begin to recognize and learn. Even someone becoming less communicative, someone who was previously really talkative, might be a great sign that they're actually struggling with a lot at that moment. Once we've recognized that escalation, we want to be able to respond accordingly. And there's a stepwise approach that we can take to that. It begins by thinking about the environment that person is in. Where are they? What's the space that they're in? We need to make sure we respect that space and actually give them enough space. Sometimes just distancing can actually help the temperature in the room come down and can help a lot. We want to introduce ourselves when we then are going to interact with them. And that may sound really obvious, but oftentimes we forget to do that in the heat of the moment. Them knowing who we are, why we're there, what our role is, really, really critical. And then following that with listening and observing, also that we can ultimately identify their feelings and their needs. We really want to understand what they're feeling and what do they need to feel safe and in control. Again, underlying this is a loss of a sense of control, a loss of a sense of safety, and we need to try and restore that as much as possible. The beginning part of that is really to validate their feelings. We don't have to agree with what they're saying, but we do need to respect it. If they are telling us they feel a certain way, we have to acknowledge and validate that that is okay and that that is how they feel, and we'll work with that. If someone's being really repetitive, that might be a sign that they're not feeling heard, and we might want to come back and actually make sure we really do the validation we need to before we move on. As we communicate with people, there is a lot to that, both from a nonverbal and a verbal standpoint. Ultimately, we're trying to build a connection and help that person regain power and hope in that interaction. We do that by giving them choices. We avoid giving directives. All of these pieces of how we communicate here do need to be really intentional. What I want to really focus on and highlight today, though, is the importance of self-regulation. I alluded to this before, but this is really a key part of this de-escalation pathway. Part of this is recognizing that as anxiety and stress rise, our ability to do cognition or think clearly and make good choices decreases. That's just a human part of how our brains work. When stress rises, our ability to make good choices goes down. That change in our cognition happens both in patients' families as well as in professionals. And the key is that with professionals, it actually lags. That curve at which the stress is rising and cognition is decreasing lags that of patients and families, because they're on the leading edge of the stressful situation, and we're coming in afterwards. And so just as they are maybe beginning to get ready to calm down and actually not proceed to the crisis stage, we're now at our peak of anxiety and our nadir of being able to think clearly and make good choices and communicate intentionally. And we actually risk overreacting. And this is part of why it's so important that we self-regulate, so that we don't do that, so that we actually allow that de-escalation a chance to work. There are a lot of different ways to think about self-regulating. One is, again, understanding how we're feeling and being able to process that. But two, I think, is letting go of a few conceptions that we have in our head. And I know for me, this is a big part of what I work on. I think of this little mantra, which is abandoning the need to be right, to be in control, and to have the last word. And those concepts, I think, in healthcare, as healthcare professionals, may not feel great to us. We like to be right and be in control and have the last word. We've done a lot of training. We know what we're doing. This is our job. This is our work. But I think in these situations where we're trying to de-escalate, we really have to relinquish that need to be right or be in control or have the last word. We need to give that up. It's really no skin off our back to give that up and give that to the patient, allow them to regain that sense of control so that we can bring the temperature, the emotional temperature, down in the room, so to speak. Ultimately, our ability to self-regulate well depends a lot on our ability to debrief with patients and families and professionals after these events occur. So that gives us just a minute or so to cover the last topic, which is this topic of peer support. I think all of your organizations likely have some sort of peer support program. I would argue there's probably rooms for improvement there. We know that the current state is that we all suffer a lot. It affects us in many ways. It's more than just adverse events. It's also our life and interprofessional interactions that are happening. We also know that we turn to get support, not just from our peers, like me as a hospitalist turning to a hospitalist, but also to other disciplines, other people on the interdisciplinary healthcare team, as well as our partners and loved ones outside of the healthcare setting. And so I think some of the opportunities with peer support are to begin shifting the narrative from the historical one where we put our physical, mental, and emotional needs behind those of others. Also where we say that self-care is selfish and puts a burden on our peers, and where we must be strong and we have to push our needs to the back burner because we've actually got to be there to serve the people that we're there to serve. That's the historical narrative, and I think we actually need to move to a more modern or evolved or a newer sort of narrative where we proactively are caring for ourselves in the setting of acute emotional distress so that we can keep caring for others, because we know that if we don't do that, if we don't take the time to perform self-care, we're going to burn out. Acute stress is going to turn into chronic stress, and that's really not good for anyone because then we're not around to help at all. And so shifting this narrative, really rewriting this, I think is really important part of our work. As we are responding to acute stressors with peer support systems, I think we also can shift the paradigm, the processes, the systems that we're using to more reliably take people off duty. So, when someone has a healthcare professional has COVID or they develop a fever at work, we're really good these days about saying, oh, you got to come out of work, right? You can't work anymore. You got to come out. That's great, but I think we need to get that good at finding ways to identify people who are under acute emotional distress, professionals that really need to be taken off duty to recover from that event. We also need to more reliably connect our professionals with peers. I think a lot of peer support programs are out there and are great, certainly in organizations I've worked in, but maybe not have been utilized as much as they could. Forming more reliable connections is the next step. And I think we need to go beyond the walls and actually do some outreach, recognizing that especially family members and loved ones are providing peer support, essentially. How do we train them so that they understand the stress continuum and what the resources are to be able to support somebody? How can we begin to offer a broader, more comprehensive support network for everyone that we work with? So there's a lot to think about here. We've talked about several different forms of acute emotional distress among patients, families, and healthcare professionals, how empathy underlies that all in trying to respond well and constructively. And we've talked about trauma-informed care, acute de-escalation, and peer support today. So I thank you all for your attention, and I look forward to our interactive portion of the session and any questions that might arise, and hope that you might reach out afterwards with any comments or feedback. Thank you again.